morning, Lesley and Paul. How are you both today?
Good, thanks, Jenny.
Morning, Jen. Really good to see you both online today, guys.
Lovely, lovely. Glad to see that you're well. Firstly, thank you for taking part in our podcast and sharing the fantastic work that you've been doing across Staffordshire. It'd be absolutely invaluable to share your improvement journey so far. Lesley, you've been referred to as one of the most proactive developers for unscheduled care in the NHS, and you've managed to roll out the unscheduled care coordination model across the entire localities of Staffordshire.
Yeah, right? Yeah, really proud of where we've come from and to Jenny. Yeah,
absolutely marvellous. And without delaying things anymore, I'd like to hand over to Paul. And Paul, I know you've been heavily involved in the development of the unscheduled care coordination centre concept and the development of the centre, and that you've worked extremely closely with Lesley. So could I hand over to you, Paul, to take us through the improvement journey so far?
Yeah, thanks for that, Jen, and absolutely echo your comments about your introduction to Lesley. She's Lesley and the team are absolutely amazing in the way that they've picked up the concept, but I think the trick is being able to operationally deploy that. And I think the most outstanding thing for me about the way Lesley and the team work is this culture of continuous improvement. You can't sit down with Lesley for more than 5 minutes without hearing those words, test of change. And every week after week after week, there's tests of change. And that's quite remarkable, I think, because when you actually go and see Lesley and the team, it's just tough enough delivering business as usual, let alone tests of change alongside business as usual. So it's a remarkable situation there in the North Staffs team. And I know the guys are working really hard now to get that county-wide rollout. So Lesley, thank you for your time again. It's lovely to see you online. Just a couple of little questions really for you then. First one being around how you found the concept of unscheduled care coordination how has that benefited your patients, do you think, that you've been serving there in Stoke and North Staffs?
Okay, thanks, Paul. Thanks, Paul and Jenny, for the fabulous introduction. It's a pleasure to share our journey, really. And I always start with where the journey started for me personally, as well as the team. Anybody who knows me knows I've got a huge passion for admission avoidance. I had a very poorly dad who's actually passed away now, but for years his needs were exactly what the unscheduled care coordination could provide for patients, right care and in the right place first time. We talk a lot about alternative pathways, we talk about getting it right for the patient, and I have the privilege of being in the NHS for 34 years. I've been able to get that right for me dad, so I wanted everybody to be able to have that John Johnson experience, as I call it. So we had a very small triage service within North Staffordshire that's quickly grown into the titled Unscheduled Care Coordination Centre now. And that's about us giving real-time access to healthcare and social care professionals. It's about us utilising a trusted assessor model. So no referral is particularly challenged. It's about a clinical conversation about that patient's need, about the response time that's needed for that patient, and also around the acuity and what clinical response, so that level of clinical response that's needed. I would say everything that we is patient-centred. So we all look at every referral as an individual. And one of the things that we've instilled within our team is that everyone's got an opinion, a perspective, and something to bring to the table, really. So we get referrals from GPs, care homes, our West Midlands ambulance colleagues, community nurses, and we utilise heavily also by the Acute Trust for some supported early rapid discharge. So I think very early on with the journey, Paul, when we first met, it was identifying how we're going to roll that out proficiently and efficiently, and keeping it safe for me. It's paramount that these patients with our 2-hour response time are triaged correctly. We have that clinical conversation with the person that's referring in. We do ask for a full set of clinical observations just so we can rule out any red flags. sepsis, anybody that could be having a stroke or a heart attack. And I suppose the real-time access for me is that we need to be able to stand down these professionals that are calling in. They've got their jobs to do, their business as usual, and we want to take that from them, give them the reassurance that we will respond. That isn't always our crisis response 2 hours. It could be passed to any community service. And again, I think having had 20 years of working in the community, we've got a bit of a DOS that we've built up within the team. We've got the expertise and the experience and the partnership and collaborative working with our community providers. So that integration, that collaborative working with all those systems is, I think, how we've rolled out the unscheduled care coordination so well.
Lesley, that's absolutely brilliant. And for colleagues listening in, the Dragon's Den question, as I always say to folk, is what problem are you trying to address? And for a number of years, I think colleagues have been expressing a kind of frustration around the lack of what Lesley's just described, having real-time access to services for patients that are not seriously ill or injured, but might need something from the system. And the concept actually being, instead of taking that patient to a hospital environment and allowing the hospital then to work out what's wrong and what needs to happen, for the system, then the health and care team to work out in the community what's the best response and then take responsibility for delivering it. This is a complete game changer in the way we respond to unscheduled care, and this is the unique selling point of the concept. And Lesley's delivered it beautifully using the team she's got. So Lesley, just thinking about going forward then, how would you like to see care coordination developed going forward? What kind of plans have you got to take it even further and innovate it even more than you've done already?
So obviously within the 18 months that we've been live, Paul, as you've said, any rapid improvement programme, any test of change, I think I'm going to have that tattooed on my epitaph, as it were. And I certainly know that the team are up for any change. They are change agents, as you describe, everyone. They want to get this right. We're all very similar age group. So if we get it right now, and then by the time I'm in my 70s and 80s, then I won't be conveyed to ED inappropriately. So moving forward, we're currently undertaking an ED in-reach test of change with our acute provider, the Trust at Royal Stoke at the moment. And we very quickly realised that we needed a two-pronged approach with that, really. It's looking at data collection of how we can engage further with our referrers. So educating and empowering our local paramedics, our GPs, our care homes to understand what the best journey is and outcomes can be and experience for our patients. We want to continue working with them, showing them the art of possible of what we can keep at home. We describe that we take ED to the patient within their own home. Some people don't like that and feel that's too acute. We label it as subacute conditions that would you be calling 999 for, and actually can you think of an alternative option of keeping them at home safely? Our staff have grown their skills and competencies, their prescribing formulary, and working with our two consultants who offer us medical governance. It's a huge option that we can then, the unscheduled care coordination can offer these alternative pathways. One of the things we'd also like to do is become an option for some of the SDEC. So we've got ambulatory emergency care centres, surgical assessment units. We'd like to become the one-stop shop, as we call it, that single access point for some of those options. We feel that we could still keep some of those patients that GPs would want to send into these ambulatory centres in an acute trust at home, treat them, initiate a medical management plan, leave them on our virtual ward and manage them for up to 5 days then, caring for all their holistic needs. One of the other things we want to look at is, again, we've gone through the pandemic, is a sort of reassurance rehabilitation offer from our triage centre as well. So we've got an oximetry at home centre that monitors and supports patients to self-manage themselves for up to 14 days following discharge. this has been a huge game changer, I think, for patients who have been in fear of going home following a COVID diagnosis. They're fearful of the what if. They're fearful if they've got no one to contact. Do they call 999? Do they call their primary care GP? We want to offer them, and we have done three times a day call of re-abling them and a sort of self-monitoring support mechanism. And then I think the final bit of unscheduled care, Paul, is how we develop pathways further within community services. District nurses, I don't think, have ever had an option to escalate to a senior clinician that can help them with blocked catheters, with palliative and end of life supportive needs, symptom management. And we want to be that option that any clinician can call us, have that clinical conversation and find that alternative outcome for our patients.
That's just amazing. And you know, I think having been in amongst you and the guys and listening to it actually working, one of the key things that kind of really brings to life what you've been saying was I was with you guys one day, and I heard a conversation between one of your consultants who specialises in the acute and emergency medical work, and one of your advanced practitioners who goes out visiting, delivering care for you. And the consultant actually said to her, there would be absolutely nothing more we would do for this lady that you're going to see if she was admitted into an acute medical bed than we are doing for her now at home. And that got me thinking we're going to reframe how people think we need to use hospital. Because when you can deploy that rapidly and that efficiently, that level of skill. So quite clearly, this patient was one of a group of patients that were borderline clinically, whether or not we could actually care for them in their own normal place of residence at home or wherever, or have them come through to hospital. But with that engagement through your virtual board rounds, and you've got your consultant input every day, haven't you, with those, it was actually allowing those advanced practitioners to deliver those, you know, that aspect of care at home and under the medical governance of a very senior clinician. So there was absolutely no clinical reason why that lady should be occupying a medical bed, let alone going through ED. It was an amazing thing to see, and I think you're recasting how we deal with unscheduled care. I think across the NHS, it's fantastic to see. I can't thank you enough for what you're doing and all your enthusiasm, and especially when I know it does get incredibly tricky at times to keep the day job going at the same time you're doing tests of change. I think from an ECIST point of view, it's our absolute pleasure to be working with you, because, you know, it's just brilliant what you're doing and we love it, absolutely love it. So thank you for sharing your experiences with us today. Jen, thank you for bringing us all together, and we'll look forward to supporting you going forward, Lesley.
Fantastic. Thanks, Paul. Thanks, Jenny.
Thank you, guys.
Lesley, can I just say that the John Johnson care experience for me really hit home, because I think as clinicians we join the NHS to provide to all our patients what we would want for our family, and to be in a position where you're delivering that, I think is absolutely amazing. And to get that ethos at the heart of the unscheduled care coordination concept, I think is everything that the NHS is about. Individual, holistic care in a timely manner in the right place.
It's a privilege, Jenny, to be able to do it, and I feel it's not only my dad's legacy, it's what I always spoke to him about. He was petrified again into hospital, and if I can give that opportunity and experience for, do you know what I mean, hundreds and thousands of other people, we all talk about right time, right care, right place. That's exactly what we want to continue doing.
And it's that simple concept, isn't it, of having a clinical conversation based on clinically what does your patient need next, not what service do they need next. It's that simple conversation around the clinical needs of that patient at that time, and being able to respond in a timely manner to improvement and deterioration. So Lesley, Paul, thank you both for your time, and good luck for the future, and I look forward to hearing what goes on next. Thank you,
Thanks,
guys.
Jenny.
Bye.
Thank you, guys.
Jenny. Bye.
Cheers, Jen.